Welcome, everyone. We'll wait just a few seconds here to let everyone join, and then we'll begin. All right, welcome to the Healthcare Lounge. The topic today is the power of care navigation to maximize health plan performance. So now I will turn it over to Nelson.
Thank you, Kendall, and welcome to this episode of the Healthcare Lounge. I have a real treat. Some of you may have caught our special guest today on an earlier Healthcare Lounge when we were talking about bundled surgeries and other types of bundled care. But today we're talking about a bigger picture and really the linchpin to the success of bundles in a health plan. In fact, the linchpin to the success of really any cost containment that requires active employee participation. So let me introduce our guest today, my very good friend Doug Geinzer, the founder and CEO of High Performance Providers out of Las Vegas, the Sin City. Doug does not fall under that category. It's just named for the city. It has nothing to do with Doug. And Doug has been a pioneer, I would argue, in the use of high quality providers in a direct contracting format. So bundled surgeries in particular, Doug probably knows more surgeons across the country than any human being on the planet. But today we don't want to talk about, we're not going to talk about bundles and direct contracting, but rather how do you get bundles and direct contracting and other cost containment where the employee needs to be an active participant in the process? How do you make that successful? As our topic today is the power of care navigation to maximize health plan performance. And so the topic is care navigation. Now, some of you will be familiar with what I'm about to share with you. If you are not, you want to avail yourselves of the opportunity to get a copy of the white paper that Doug wrote called The Power of Navigation. I thought so much of it, I offered to write a foreword to it, and you can read that in this copy. There's the QR code. Kindle is putting the link, if you just want to copy the link and put it in your browser. It is in the chat. The power of navigation is such a remarkably in-depth and comprehensive look at the role of navigation, why it works, how it works, and what you have to do to make it work. So in-depth that I got a call one day from one of our top next-gen benefits advisors who said, "What the hell is Doug Geinzer doing?" I said, "What are you talking about?" He said, "Have you seen this new white paper he's put out on navigation?" I said, yeah, I'm very familiar with it. He's giving everything away. Why would he do that? Well, that is simply how Doug operates. So before we jump here, make sure you get the QR code or you can get the link in the chat. And before we jump to Doug, let me, a little housekeeping. As questions come up, and I assure you they will, do not do as I am wont to do and say, "Oh, I'll remember that question and ask it during the Q&A section," which we probably will have. We may get to a Q&A section. But go ahead and write it down now. Put it in the Q&A box, and we will get to those questions probably throughout to sort of to spice things up, see if we can answer relevant questions in real time. But use the Q&A box, not the chat box, and we will get to those questions, as many of them as we can. All right. Doug, welcome to the Healthcare Lounge. Welcome back to the Healthcare Lounge.
Happy to be here, man.
So this is, and you and I have had a lot of conversations about this topic, and I absolutely agree because we've both seen, and a lot of advisors here on the call, any employers who have put cost containment strategies in that required the employees to say, "Oh yeah, I'll do that." Um, know that generally the ROI is woefully lacking, and you've identified the problem as a lack of effective navigation. Might be a lack of navigation entirely, but even when navigation is arguably in place, it doesn't always work. So you've done a tremendous amount of research, interactions with many, many navigation firms to see exactly what they do, how they work, what are the internal components, and the ones that do work, what do they do? And so much of this information is in the power of navigation. But if just take a moment or two, if you would, and talk about how you sort of backed into this whole navigation issue from working with bundles and direct contracts, and then why you felt it was so important.
Sure. So for just to kind of level set a little bit, so I've been in the bundled surgery direct contracting space for probably around 10 years, putting together one of the first bundles in the country before bundle was even a term. We just called it offering all services for one price and getting paid. Along the way, we started getting into bundling. It just seemed to be a more logical term that people would associate with. So written literally thousands of direct contracts around the country, all 50 states, um, built networks for some of the larger COEs that are out there and brought them providers that I identified that were delivering better health outcomes for a lower bundle price. And I look across the ecosystem, and there's some great groups that are out there, but utilization typically is sorely lacking. And so I said, what is the purpose of building these direct contracts if they're not going to get properly utilized, and what is causing that? And as we dove into that problem, we quickly discovered it comes down to poor care navigation. And I think there probably needs to be clarity around what is care navigation, because a lot of folks say, well, I have this group built into my health plan and they do care navigation for me. But at the end of the day, really what they are is glorified appointment centers. So it gives the member a phone number to call, and the recipient on the other end of the line is taking that call, and they're just going to the PPO book and they're saying, where do you live and what type of procedure do you need? And let me get you scheduled to a provider that's close to you. It's not really care navigation until you start bringing in the quality metrics and the cost containment opportunities, which is really changing the site of care. That's where you get into care navigation, and almost argue that I would call it care redirection. Because if you think of the current ecosystem, the current structure, the PPO is really a one-way street to the hospital. And when you're in the bundled surgery world, when you look at the episode of care, the cost for that episode, about 70 to 80% of that lives in the facility fee, which is in the hospital. And so that's where we're able to get the largest cost containment from a direct contracting strategy, is move the site of care from a hospital to a surgery center. And you could typically find somewhere between 40, 60, even 70% cost reduction in that bundle or that episode of care. But the other upside to it is you get a bump in quality, which most people go, how can that be? Aren't hospitals better places to deliver care? And the simple answer is no. And the reason is the infection rate, the challenges that live inside of a hospital are greater than they are a surgery center. And there's really one factor behind that, and that is the autonomy inside of the operating room. And so when a surgeon goes to a hospital, they are assigned that OR team. And many times when they walk into that OR, they do not know their team. They look up and they see an anesthesiologist that they may or may not have worked with before. They see a scrub tech, the first assist, an OR circulating nurse, and they may not know these folks. And so imagine being a high-performing surgeon that's really relying on the instrument handling and the protocol with a team that you've never worked with. Creates challenges. Now take that same scenario, move it to a surgery center, and it's many times it's your OR team that you as a surgeon hand select. So it's your anesthesiologist, your PA, your first assist that's helping you with that procedure. So the member's under gas, under anesthesia, a little bit less time, and they get a quicker recovery and they get a better health outcome. So that's where you get the win-win. And so to kind of come full circle to your question, it's how do we take these cases that are on the one-way street to a hospital, intercept it at the earliest point that we could possibly intercept that case, and redirect it many times to the same surgeon, just different facility, and get that member the care that they need in a bundle case arrangement. Because as benefit advisors, as most are on the phone, we're all about how do we bring cost containment to the health plans that we manage, and that's by far the best way to do that.
So the idea is, and navigation works on one level because it's helping the employee navigate through the healthcare system. But when it comes to these cost containment solutions, it often is redirecting, whether from a surgeon that does not have good qualifications, good outcomes, to one that does, or to a different location for the surgery itself. In the white paper in Power of Navigation, you talk about how the employee is navigated or redirected or guided. Uh, what are some of the styles? Let's just say styles. Later we'll get into the types of companies, but the styles of navigation you've seen.
So in terms of the styles, you have proactive and reactive are the two different ways. And we want to get as proactive with the member as possible, but that requires member education. And we all know at enrollment meetings, they walk out of that meeting not remembering very much. So obviously getting the program in front of them on an ongoing basis, and really what motivates the members more than anything is the elimination of the copay, deductible, and coinsurance. Because today, most members are delaying care simply because they don't have the money to cover their 20% copay. So let's kind of give some apples to apples comparisons or what that may look like. We'll use the common one that everybody uses, which is a total joint replacement. Call it a knee or a hip. Traditionally, when you look at the claims data across almost any plan that's not using this type of technique right now, that total joint replacement is more than likely going to cost the health plan somewhere between $60,000 and $80,000. I've seen it as high as $200,000, $300,000, but on average about 60 to 80. We get those done all day long in a bundled arrangement in a surgery center for 20 to 25,000. So what does that mean financially to the member? What does that mean financially to the health plan? What does that mean financially to the provider? Which are the three parties that should be involved in the transaction? So the purchaser, the health plan that's writing the check, when you reduce that spend from 80 grand down to 20 grand, there's a significant savings there. It's far greater than you'll find in any other area of the health spend. For the member that's paying a 20% copay or their max out of pocket, they're saving 14, 16 grand, depending on the plan construct and how many members they have in the plan. And so therefore, that's where they start delaying care because they just don't have $10, $12, $14,000 in the bank. When you make it affordable, they could seek out that care. And now all of a sudden they could return to work and they could return to life a lot quicker. From the provider standpoint, providers love this type of program just because they are establishing a price, a rate that they know that they're going to get paid, and they're going to get paid in a timely manner, or in their words, what they call RCM, revenue cycle management, because they have the same common, I don't want to call them an enemy because I don't want to do that, but the same challenges with Blue Cross United, Cigna, Aetna, as we do as those that work with health plans, because they fight to get paid. The average time for payment, we're finding right now to be 30, 60, 90 days. I've seen some claims go out 120. And the average practice spends about 29%. And that's a stat that's put out there by the MGMA, Medical Group Management Association, HFMA, Healthcare Financial Management Association. These doctors are spending 29% of their revenue collecting it, which is a burden to them. And so when they see this type of opportunity of, hey, I'm going to get paid a known amount, I'm going to get paid at the day of service or 15 days post-operatively. It's a no number. They're willing to lower their rates to satisfy that and earn that market share. And that's where the three parties, again, that come together, the patient, the provider, and the health plan come together, and the three parties that matter all benefit from this. That's an exchange of value.
Speaking of the value of reducing the cost of surgeries, the National Business Group on Health just released a survey of employers. And while cancer remains the number one cost driver, the number of employers who are listing cardiovascular as a number three has risen from 30% to 40%. And I had a good friend go in 2 weeks ago for open heart surgery. Had another friend go in about 6 months ago, open heart surgery, all around cardiovascular issues. Bigger cost driver, and number two being MSK, musculoskeletal, which leads to joint replacements, again, surgeries. So just to emphasize your point about how, and then oftentimes there are cancer surgeries as well, mostly not surgery, but often. Um, so this is a really, really strategically important tactic, but why doesn't it happen as often as it could?
I think we all know the answer to that. I would call that misaligned incentives. That magical term that we all know, MLR, medical loss ratio, where the commercial plans get paid more the more they spend. And so the more they spend, the more they make. That's how, they generate their revenue. And by sending it to the hospital, they're able to charge higher fees, and the hospitals win and they win. So those two parties are absolutely misaligned. And, a little known fact, probably 70, maybe as high as 80% of the surgeries that are currently being conducted in a hospital don't need to be. They can be done safely in an ambulatory surgery center. So let's kind of close out a little bit on the movement in the cardiovascular space. Several years back, a lot of the surgery centers began to start building cath labs into one of their ORs. They're not going to put it in all of them because there's not a high enough volume yet. But that allows the surgery centers now to start capturing some of those cardio cases that were once just going straight to the hospital, nowhere but the hospital. MSK is hands down the easiest area to deploy because most of those are not an emergent case. They are absolutely scheduled. The only barriers that may pop up in place could be a BMI level or the comorbidity of the patient, because the surgery centers like to keep, they don't like to get too risky. So they usually say anything over 42, 44 must go to the hospital. But most of those are safely being done in a surgery center. So, and if you look at your MSK spend, that's hands down the largest part of the spend bucket that we're able to redirect. So if folks were looking to deploy any type of direct contracting strategy right now, the single largest group that I'd be looking to direct contract with would be an orthopedic practice, because that's where you're going to be able to find the most cost containment.
In your research of these different types and different types of navigation firms, what have you seen that makes for effective navigation?
So the mining of the claims data, and now I know that's a tough thing to do, but if you could get into the EHR data, that's even better. So let's look at what you may be able to find in the claims data before a large event occurs. So let's kind of hone in on surgery, because that's the area that we specialize the most in. There is never a surgery, regardless of the type of surgery, that is done without an image being done first. And so many that are on the phone have deployed an imaging solution, whether that be green imaging or one of the others that are out there. And so looking at the claims data and mining just the images and building a rules engine that says, did the member take the right pathway or the wrong pathway? If they took the right pathway, call them up, congratulate them. And while you have them on the phone, ask that simple question of, hey, by the way, what was the outcome of that image? Is there anything going on that we may be able to be of further assistance with you? If they took the wrong pathway, it's an educational opportunity of, hey, bud, why did you go down the hallway of your doctor's appointment to get that MRI? And that MRI that cost $4,000 and you took $800 out of your pocket to pay for that. Bad move, bud. In the future, you do know you have this benefit to go over here and all of that will get waived. So we won't be able to refund your 800 bucks, but let's make sure that that doesn't happen again. And oh, by the way, while I have you on the phone, what was the outcome of that image? Catching that image is instrumental in terms of being able to start the redirection process, because many times people will try to intervene at the time of pre-cert or pre-auth. And a lot of times that's just a little too late because that member may be in the waiting room of the surgeon's practice. And I've even seen some pre-certs being done post-operatively, which the procedure's already been done. So the name of the game is to get ahead of the journey that the member is going on at the earliest point imaginably possible to be able to help them out. And that member will be very grateful and thankful. Some of the navigation firms that I'm seeing now are starting to get very, very proactive and really building their care navigation companies around outbound phone calls and proactive outreach, mining that data, looking for things like in total joint replacement. What typically occurs before that? A series of cortisone shots, an HA shot, which are just ways of, I hate to say, delaying care. You know, they're going to extend the life of the joint for a little bit. But when those treatments start occurring, more than likely they're heading towards a surgical path. So how do you get ahead of that? And by mining that claims data with an outbound phone call, hey, how you doing? We see that you've been doing this. How's your knee doing? How's your shoulder doing? And how can we help you? That's becoming more of the proactive approach that we like to see.
I love the idea of watching for what I call canaries in the coal mine. The idea that canaries are used in coal mines because they're more sensitive to carbon monoxide and other deadly gases and often get sick before the miners do. So it's an advanced warning system that the air has gotten dangerous down here. Now they have carbon monoxide detectors, but back in the day they used canaries. And you know, it's an apt analogy because that test is telling you there's sickness involved. There is, you know, disease or, you know, a problem involved. There's a question. I'm going to jump sort of, this is a non sequitur, but it's a really good question. Have you had any success or seen any success getting cooperation for using a navigation solution and, of course, the cost containment tools? No reason for navigation if you don't have the cost containment in place. When the ASO is a BUCA, in the case of their self-insured plan, UMR, what are the realities of that?
So it's becoming more and more accepted. UMR is actually one of the more willing to work in this type of environment. They will all try to give some initial level of pushback, stating you must use our contract, you must use the favored nations agreement. There's a lot of language that they'll throw at you. But at the end of the day, the plan administrator is who controls the plan document, and the network is subservient to the plan. And so it's just a matter of pushback to say, it's our plan. We could run our plan the way that we'd like to. And it's installing what we would call sometimes a bolt-on solution or a side-by-side solution. And it's basically you're writing that SPD amendment as an out-of-network benefit. And when it's an out-of-network benefit, it allows you to maintain control of it. So it's an optional benefit for the member. The member doesn't have to take it. They have the option of taking it. So if that member chooses to stay in network and take the traditional pathway that they have been, they're going to be, you know, responsible for their 20% copay, deductible, co-insurance, all of that stuff. Or if they take the out-of-network benefit and call the navigator, they will have access to tier 0 or the 0 out-of-pocket plan. And that's how you're able to get around that. Then it's a matter of how do you get the reporting back to the TPA? And so there's various tricks of the trade that people do. Some are going so far as to extracting the funds directly out of the plan asset account and just sending a 0 claim over to the TPA so they could run their tally of what is being spent. UMR, again, from what I understand, I don't really get involved too much at that process, is more allowing this a little bit more than say a Cigna that wants to control the pre-cert process. Blue Cross around the country, depending on which franchise, has been amenable to this and been allowing this to happen. And so that's usually the first step, in my opinion, of somebody that's looking to move an ASO plan to an unbundled TPA driven plan. The first way is, let me bring in a cost containment solution. We all bring in PBM first because that's the easy duck to shoot. But where the bigger cost containment is in the medical spend. And in order to get that to perform, you need to have care navigation. So that's why all of these things align the way that they do.
Another question. Doug, what techniques have you found useful to help employers embrace the power of redirected care?
Yeah, great question. So what we have found great success in lately is holding open houses at one of the local area surgery centers. We just did one down in Los Angeles with a client of ours, Commons Clinic. We've got one coming up in Chicago with American Hip Institute. These are some of the fine, and actually, Nelson, we're doing one with you down in Phoenix next week or next month.
Next month at our mastermind summit. Yeah, really
Yeah,
excited about that.
and we've done one here in Vegas for you. So what does that look like? What does that mean? The reality is a lot of folks don't understand what a surgery center is and how it differentiates from the traditional course of going to the hospital. So we will hold or host some type of open house, a site visit to a recognized surgery center in the area. And when they walk in, they see what it looks like. It's not vinyl floors and plastic chairs and a glass window where you have a woman behind there saying driver's license and ID card, please. The more sophisticated groups that are in this, they have plush couches, they have carpet on the floors, they have water fountains coming out of the walls, and many times they greet you by your first name when you walk in because they know who you are in advance, because they know that you're what I'd call a VIP patient, because these providers want to do more and more of this work. So this allows groups in the area, and a provider, or I'm sorry, a benefit advisor will host one of these. They'll invite a lot of their clients in the local area, others that are involved in the ecosystem. They gather there, they get to meet the surgeons. So all of a sudden they get to realize there are people in the community. They get to hear the outcomes that they're able to deliver. They get to understand the surgeon's frustration with the bucas, the same frustrations that we have on the other side. They get to walk down the hallway, see what an OR looks like, and really understand what the procedure looks like. And they start learning, wow, the member doesn't need to stay in the hospital for 2 or 3 days. They could come in, and many are discharged before lunchtime because they're under anesthesia 25% less time because of that OR autonomy that we talked about earlier. And they get them up walking, if it's a total knee or hip replacement, walking the day of surgery, literally an hour and a half post-operatively, to burn off that anesthesia because that speeds up the recovery time. So it's just, it gives, that's probably the best way to get adoption with the employer groups, is to let them feel it, touch it, and talk to the surgeons.
You know, and I'll speak to that, Doug. When we took mastermind partners for that back of the house backstage tour in Las Vegas, with the surgeon who guided us through and shared so much. Outside of one of the ORs, you'll remember there was this large stack, a big mound really, of clear plexiglass, clear plastic tubs,
Yep.
and they had tape on it written where it would say Johnson, a date, and then knee, hip, etc. And we asked, what are these? And he goes, oh, that's everything the surgeon needs. The nurse will pick that up, walk into the OR. That's everything the surgeon needs. And somebody said, do you know what the cost is for those? Because I know down to the penny what everyone costs, which is how they can price it the way they do, because they know the cost. Go to a hospital, ask any of the surgeon up to the CEO of the hospital. No one will be able to tell you what that surgery cost. But they do. The other thing I remember, there was a sling. It might not be the right word, for a harness that attached to the ceiling. It slid back and forth with the patient locked into that harness to hold them upright so they could walk after their surgery, and we're talking right after their surgery, within hours, down the hall, turn around, come back to work that anesthesia off and to start the therapy right away. Let's not let it lock up and get stiff. Yeah, I was fascinated. The thought that had gone into things like that. I'm really excited for the Scottsdale Center for Robotic Surgery that we've got that tour you've arranged with Shane Martin, the surgeon, because I think the more advisors understand, the easier it is for them to explain to their clients. And that's why at the mastermind, we want to do things like this for our advisors. Okay. So here's sort of the big question, Doug, in my mind. There are more and more companies offering navigation. First of all, what is everything in life occurs on a spectrum. So what does that spectrum look like in terms of the types of services being offered? And then I'm going to ask you to talk about the types of firms you see that are offering some or all of those services on the spectrum.
Sure. So I think it's important to understand who owns the navigation company and where their revenue stream comes in from, because that's going to allow you to quickly identify the misaligned incentives. So some of the larger groups that call themselves care navigation, they are hands down the larger ones that are out there. But again, they are steering people right into the network. So they may become a navigation firm for an outside party navigation firm for one of the commercial carriers, and they're only looking into the PPO network. Some of them have gotten a little bit more advanced and they start looking at quality metrics, but at the end of the day, that's not going to bring you the cost containment of the procedure itself. You'll get cost containment from the improved quality outcomes, which is significant. I don't want to underestimate that, but where you find it is moving the site of care. And so really looking at that. So as you're interviewing and talking to care navigation firms, understanding what their business looks like, how they intercept the patient, and I would call it an interception, and at what point that they do, and what tricks of the trade that they deploy to capture more of that business. We always look at several different KPIs that we'll build into the system. One is, what is the redirection from the first call over to care navigation that's going to redirect? So, a lot of the traditional care navigation firms measure things like time to resolve a phone call, which is a BS KPI in our world. We want to know, did the member become aware of an opportunity to save their money? And what was the handoff rate from first call to real care navigation? And then inside of care navigation, the KPIs, the two measurement points that you should be looking at is what is the take rate of both surgical and then also diagnostic imaging, because again, diagnostic imaging is your early indicator that a surgery is coming at you. And so looking at those is going to allow you to measure the effectiveness of that care navigation firm. So asking those tough questions, they may or may not be able to answer them. And that should let you know whether you should or should not continue a conversation with them.
All right. Types of firms. What are you seeing? What are you seeing currently, or what have you seen historically? Where are we today, and where do you think we're going?
So, there's TPAs that will say that they do it. I would argue that most do not do it effectively. There's those that will bolt on an outside third-party medical management company that may be able to capture it there. Again, asking the questions that I just asked will let you know their effectiveness. There are some that are very effective at it, and there's others that are just following the typical protocols and doing the UMCMDM. Sorry for that. It's utilization management, case management, disease management. But are they doing redirection? So that's probably what I'd ask there. What is very unique right now, Nelson, is we are finding when we published that book, our intended audience was the benefit advisor. We figured this was a way to kind of share the playbook. And sorry for the benefit advisor that was upset that we shared some trade secrets that are out there, but this is for the betterment of the ecosystem. But we wanted to share that playbook to increase the utilization of high-performing navigation firms. And what we did not expect from that was the volume of inquiries and downloads from care navigation firms that were, I'd call them status quo, that are going, why are others eating my lunch and how do I stop that? Care navigation firms that were just getting started going, oh, we should be looking at this a little bit different. Then we also had a lot of inquiries from TPAs saying, we've been thinking about bringing this in-house, but we want to do it a little bit differently. So there's a lot of movement in that space. And then some of the larger groups that get it earlier than others would be the captives and the MIWAs that are out there, because they operate obviously on the cost containment that they bring to the pool. And so the captives are the ones that are usually the first to understand this and deploy it and drive up the utilization rate. So there's some great groups out there that have cracked the code, and I would encourage you to speak with them and learn what they're doing and see how you could either participate in their captive or their group program or borrow some of their best practices.
The medical management company AIM, which of course you're familiar, Deb Alt, Nurse Deb, her medical management company. One day she called me, this was a number of years ago, and she said, I have an idea. What do you think about us changing our description of what we are from medical management to medical utilization management? And we discussed it, and so I could understand exactly what she was thinking. She's absolutely right. I said, you've hit on it, because it's not a matter of managing medical cases, right? So the difficult patient with comorbidities, multiple comorbidities, and you need to coordinate between the multiple doctors. That's medical management, and that's a lot of what AIM originally did, as most medical management companies do. Deb realized that, and I'm not trying for this to be a advertisement for AIM, but Deb, I think, was the first to realize our value is in helping patients utilize, as she calls it, the 5 Rs, the right patient getting the right care at the right time from the right provider at the right price. And notice price is last, because you do the others, price happens. The price is right. Just not to sound like a game show. So medical utilization management really gets to the heart of the value that AIM brings in most cases to the accounts that they work, to the companies that they work for. By the way, Jim Blachek, in one of our mastermind partners, just wanted to give an affirmation. He said, I can attest that we went to a center with Doug to see, this is the one in Vegas, and it was very impressive, and it certainly was. Andrew McNerlin, greetings from Northwest Arkansas, he says. Doug, what's your expert opinion? And sorry, he said, if I missed it, due to jumping on late, on encouraging a member to explore cash pay for a procedure or service that they are eligible for?
So there's a big argument out there about healthcare consumerism and can we get the patient to become a better consumer? And I would argue that the high deductible health plans prove they're not good consumers. People can argue with me on that one. I think what we need to do is give them a simple pathway of, and I hate to steal one from the attorneys, one call, that's all. But really, that's what it needs to be. One call, that's all. And that call should be to your nurse. That call should be to your care navigator. And patients will appreciate that because they do not know how to navigate the system. They get frustrated. And when you have a plan that offers care navigation, it's one less thing that the member needs to worry about because they've got a qualified nurse on the other end of the line that's going to do all of that coordination for them. And it's not just an appointment setting thing. They need to look at their healthcare, or I'm sorry, their financial wellness as well. And that is, can I help you keep your money in your pocket and find you the highest quality of care possible? And this is another little known secret out there. When members and patients are taking this pathway, The providers stat them. And what do I mean by that? They put them at the top of the list. So I'll give you an example. And this was just a case that I personally navigated this morning because it was one of my board members. Doug, I've got a big issue. I can't get into the details of it for HIPAA. I called the Mayo Clinic and I gave them what I had, and it's a 4-month wait time to be able to see who I need to see. I said, let me put one call in, and I called the Cleveland Clinic. It's a neuro issue, and I called the Cleveland Clinic here in Las Vegas, and he's got an appointment next week. Why is that? A, he's a VIP, but B, he's a cash pay client. That provider will say, will I take a patient that's coming in where I know what I'm going to get reimbursed, and I know I'm going to get reimbursed quickly, so that money is going to be in my account by month's end? Or do I put them at the back of the line behind the United, Cigna, Aetna, Blue Cross patients, and they're going to be 4 months out, and after that I've got to spend 29% of my money and wait 120 days to get paid on that claim? I'll take the cash pay patient today, and they get moved to the front of the line. So from a health plan design standpoint, that's magical when you're talking to employees saying, we're going to get you VIP level service. It falls in line with what we're doing with direct primary care and same day appointments. We're going to get you the highest level of bundled transparent surgical care, and we're going to get you that care quicker. It's a big deal.
So, the other part of that too, Doug, is if they leave that cash pay patient for 4 months down the road,
Lose them.
they may find another surgeon
Yeah.
in the meantime. So yeah, let's what is it, bird in hand? It's worth doing the bush.
Yep.
Yeah, let's get that patient in now. That makes perfect sense.
And
I didn't know about that idea of stacking,
Yeah.
where I want they're the highest value patients. It's probably another way of putting it. They're cash pay, quick pay, and and we know what we're getting.
Yeah.
It's already predetermined.
So one of the measurements that I put in place before I work with a practice, because I work with surgeons around the country, and I take those that see this model and they want to get into this model and they need help doing it. So I get them what I call direct contract ready. But in my questionnaire, in my survey, when I go in to meet with a practice, I'm asking questions. What is your current payer mix? And for, that's Medicare, Medicaid, commercial, self-pay, what have you. And I'm looking specifically at what their direct pay ratio is. Is it 5% of their business, 10% of their business, 15, 20? And how do we grow that? So that's a KPI that we put in place to go, we want to grow that number and ultimately edge out some of the other business. So there's a practice that we literally about a month ago, it was a glorious day. We started firing our commercial carrier contracts that we didn't want to do business with anymore, because our direct pay business surpassed that volume. And he was like, look, man, I go in on Friday, I make more money on Friday with direct pay business than I do 3 days earlier in the week, the first 3 days of the week with all this commercial business. We're going to fire all these guys, and I want more direct pay business. I hate to say this improves the moral injury that's going on with these providers, because it allows them to get back to delivering healthcare and get back to getting paid what they should be getting paid and not fighting with the insurance companies every day of their lives.
All right. Let's see. Okay, that's a moment of levity from Andrew McNerlin. What the heck kind of mask is that over your shoulder in the background?
That came from Panama City. So all of those pictures there are places that I travel with a forum group of entrepreneurs. And every city that we go to, I pick up some weird ass, sorry for the language, gift or something to put up on my wall. And that came from Panama City, Panama.
Panama City, Panama, not Panama City, Florida.
No.
I was going to say, it doesn't look like something you'd find in Panama City, Florida. Very cool. All right. Uh, our good friend and next gen advisor, John Clay, mentions there was a nuclear stress test at $20,000 available for $5,000 at a standalone center. He's the same test, just different locations. All right. How do you convince non-next gen advisors to understand their responsibility, both their duty and opportunity to embrace redirected care?
You
I've got
send
an
them,
idea, but I'll let you go first.
you send them to boot camp. It's until they hear the technology, the techniques and methodologies of what you teach every day within your mastermind group and within Ascend and within your boot camps, they're not going to understand the value of this. So they need to be educated.
You know, I certainly won't argue with that. Thank you. But I think there's a lot of truth there because it's a big picture issue. This isn't tactical. If you view this as a tactic, it doesn't pass muster because it doesn't fit the culture. Well, why are we doing cost containment? Nobody else is doing cost containment in the health plan. Everybody else is just spending like a drunken sailor. It's a big picture understanding that there is a different model for employer sponsored health plans. And whether you call it next gen, in our case, you can call it Rosetta type plans, transparent, high performance plans. I know you like the high performance label, but the idea is health plans can be so much more and so much better and so less expensive than they are coming from the insurance companies or being administered by the insurance companies in a self-funded arena. That if you don't understand that, you don't understand the ecosystem in which we can operate. If you don't understand, and this is the one word I was going to use earlier, results. At the end of the day, it's about results. Why do I believe in next gen benefits? Because I know they work, right? You eliminate the out of pocket for employees. In other words, you incentivize them to do the right thing. You eliminate the misaligned incentives. You align incentives where the surgeons aren't getting paid to do more. They're getting paid to do the right thing, the right time, well. It all works. When you eliminate misaligned incentives, people figure out how to make things work because the incentives are now aligned. I'm just going to respond to my incentives. Problem is, right now they're responding to bad incentives. So I do think it's a lot about understanding the opportunity to change healthcare for the employer and for the employees. Great question. Thank you. All right.
I would go so
Another
far,
question. Go ahead, Doug.
I would go so far as to say, in today's world, we're starting to face a little bit of a talent war. I know the employment outcomes yesterday were a little bit softer than expected, and they kind of backdated some things. But at the end of the day, to be able to tell a prospective employee, hey, we've got this great benefit package, and this is why we differ from those around you. We have a zero tier where we're going to give you a healthy benefits plan that's going to put you first. We give you a nurse concierge that's going to be there to answer any and all of your questions. And should you need a higher level of care, we have options in there where we're able to keep it zero out of pocket. There's value to that from a recruitment and even a retention standpoint.
Well, look at the flip side of that coin, Doug. Oh, we have a great healthcare plan. Oh, fantastic. Tell me about it. Well, it's Blue Cross. Oh, you mean the same Blue Cross plan that your competitor across the street has?
Right.
The same Aetna plan that your competitor down the street has? That's not an advantage. That's table stakes. You put your ante in, you get a book healthcare plan. You're now like everyone else. You have nothing. You could have a lower deductible, but most companies don't because they can't afford to. You could pay 100% of the employee's premium, which many companies used to do, but they don't anymore because they can't afford to, because the insurance company continues to take more and more and more and more. And that money has to come from somewhere. And finally, the employer says, I can't keep doing this. Let's let the employees pay more. higher premiums, higher percentage of premiums. We're seeing a lot of 50-50 today when it used to be 90-10, 80-20. And now it's 50-50. At what point does a benefit cease to be a benefit, in fact? But you're not competitive, or you're not more competitive because you have a healthcare plan that's a Buca healthcare plan, a traditional healthcare plan. Only when you start to move to that high performance, that transparent plan with zero out of pocket, free healthcare. Do the right thing, your healthcare is free. And that's and even if the market is a little bit softer than we thought it was, Doug, for the tech talent, for the really um, uh, hard to hire folks, particularly around technology, it is fierce competition. And that's where having an advantage with your health plan makes a huge difference, not just recruiting, but also retaining your talent. There is I was talking to the head of benefits for a manufacturing firm. And I said, have you seen, we talk about an improvement in retention, particularly with these types of plans. Who wants to leave when you have free health care, when you have lower premiums, et cetera? And I said, have you seen that in your company? He goes, well, let me tell you this. We lose employees every month to another company offering more pay, more in their paycheck. And they get to the new company and they get their first paycheck and they realize they're actually taking home less than they did working for us, even though they had a substantial raise because they're having to pay so much for their health care. I said, does that happen a lot? It happens so often. We have a policy at our company that if you return within 6 weeks of leaving, it's as though you didn't leave because so many people call us and can we come back?
Yep.
We're actually making less and we don't even like the company as much. Can we come back? So yes, it absolutely works because you can lower the out-of-pocket cost for premiums, but the out-of-pocket cost for care. And that's absolutely huge on both ends, on both ends. Okay. Another question, Doug. I understand the focus on MSK as a first priority for this type of program, but what kinds of other surgery are you seeing success with? For instance, general surgery, cardio, cancer care, et cetera.
Really all of the above. So when we go into a market to build out a market, because we do a lot of the, the network build for community-owned health plans. The first thing that I get is orthopedic. The next thing that I put in place is colonoscopies. Just sorry for the pun. There's a shit ton of them out there. I always have to say that. And then the other part is general surgery. So your hernia repairs, your lap choles, gallbladder removals, basic things. The general surgeons are really in tune to doing this. And we got one of the larger networks of those, both bariatric and general surgeons around the country. ENT is a high costly event. Most of those folks don't necessarily own their surgery center, but they do cases inside of an orthopedic surgery center or a GI surgery center. So it's a matter of once you get your first relationship established, being able to say, hey, who else is credentialed at your ASC? We touched a little bit on cardio. I would say that's probably going to be the biggest growth area in the surgery center space in the next 10 years. Is going to be the cardio side. The other one that we're starting to dig in on a little bit right now is women's health, because we really cut a lot of our teeth in the MSK space because of the trade unions and the workers that are out there swinging things and pulling wire and shoveling and things like that. But then as we start working with more and more teacher unions, they're dominantly female populations. So they're in the need of more women's health services, not OB, but more on the gynecological side. So right now we're in the process of building gynecology bundles around the country. So we expect that to pick up pretty quick as well.
All right. Few more minutes. Another question. Does your solution see more redirection with a high deductible type plan versus a low deductible option, or does it not matter that much?
So
He adds, I have, or she, whoever, it's anonymous, I have mixed feelings about introducing an HDHP alongside our PPO plan.
yeah, you still need to apply first dollar. That's law. Is it effective? It is. You need to have some type of motivating tool within the plan. So because if they're getting everything taken care of and they have zero out of pocket, they're less incentivized to save money. So there are other ways of incentivizing. I've seen everything from gas cards, because sometimes they may need to travel for one of these services. And they may say, hey, yes, we're going to have you drive 20 miles down the street. So here's a gas card to cover that. If you need to travel a member, even when you pen in the cost of flights and hotel and the companion to travel with them, you're still going to find 30, 40, 50% cost containment in it. You don't need to travel everybody, but for high cost stuff, knees, hips, spine, bariatric, you may want to look at a travel program if, and I underscore that, your local community does not have adequate care. So look for more of a center of excellence model on that. But finding what's going to motivate people is a great way to incentivize them. I've seen people set up an HSA and fund the HSA when they make good decisions, because then it's a double win on the tax basis.
Doug, and I know you've seen this some as well. I, I'm seeing more, not more, I'm seeing more interest and a little bit more activity around actually sharing back with the employee a percentage of the savings. And here's why I think that is so smart. So, for instance, if it's $15,000 savings, the employee might get up to $1,000. Let's say it's capped at 1,000, but it's 10% up to $1,000. Um, the value of that to me, it's one thing to say, "Hey, Doug, I know you've got some money in the bank, and ordinarily you'd have to spend it to get this surgery. We're going to waive that." And that's fantastic. You get to hold on to the money you already had. Fair enough. But for me to say, "Hey, Doug, you have to hold on to the money you have, and I'm going to increase that money. I'm going to give you an additional $1,000." And it's only fair because it's your decision that's allowing the savings to happen. But here's the other reason I think it's very, very important that we start doing this. You have a serious condition. There's a good chance you might have another serious condition, another serious procedure within the same year. If you do, we've already waived your deductible. So your out of pocket is much, much, much less. So this way, there's something in it for you every time, regardless of the state of your deductible. Let's see. Okay, two more quick questions. Hey, Frank Cohn, how many patients does your organization serve annually?
So I consult benefit advisors, TPAs, providers. So we don't personally do any care navigation. I would say those that are within our network of care navigation, they probably navigate for a couple million lives. Those that are on the platforms in terms of the surgical bundling platforms, a couple more million lives. So we play in a bunch of different spaces, but we don't personally do any redirection or navigation. We just consult on that process.
All right, final question in our last 2 minutes here. We need way more menopause related assistance and education, not just OBGYN. I hope those OBGYN facilities that are being built will have a focus on that. Thanks. Do you any in the
Yeah,
gynecological bundles, anything around menopause there?
yeah, I'll touch on that. So the group that I'm working with, we're building the gynecology bundles, really wants to start separating OB from gynecology. And initially I went, huh, what do you mean by that? But after I heard it, it made sense, because if you think about it, obstetrics makes sense for 1/20th of the women's lifespan. Gynecology is there for the entire. And so at the same time, and those of you that are clinical will understand this, because OB fits more in the almost the primary care space, it suppresses the reimbursement rate for some of these providers. And that may be why they're seeing more gouging on the other side, because they're trying to make up for the revenue that's missing on one side of the fence compared to the other. So I'm still working on that, but great question on that.
All right, Doug, thank you very much. Everyone, thanks for great questions, for your attention today. Doug, always a pleasure to have you in. You've
Thanks,
got so
Nelson.
much knowledge and expertise. Thanks for sharing it. And I will look forward to seeing you in
Phoenix.
Phoenix. It's in Scottsdale
Yes, sir.
for the Surgery Center tour. In the meantime, folks, we'll be back next month with another Healthcare Lounge. Thanks for joining us today. I'm Nelson Griswold. Thanks for being in the Healthcare Lounge.